Hello, everyone. My name is Summer Whipke, and along with Quincy and Hector, today we'll be doing our PowerPoint presentation on alcohol use disorder. So, we're going to start this presentation off by understanding the basics of alcoholism, also known as alcohol use disorder. So, alcoholism is a chronic disease where a person finds it difficult to control or stop drinking, even when it negatively impacts their health, work, or relationships. According to the NIH, the definition of alcoholism is a medical condition characterized by an impaired ability to stop or control alcohol use despite adverse consequences. So, diagnosis statistics: 10% males and 3 to 5% adult females in the United States suffer with alcoholism. The direct medical costs are $250 billion per year, and the risk of developing alcoholism is 3 to 5 times more likely to happen in individuals with a family history. Now we're going to talk about the pathophysiology of alcoholism. The pathophysiology of alcoholism involves complex changes in the brain's chemistry and function due to chronic alcohol consumption. Alcohol primarily affects the central nervous system. It does so by enhancing the inhibitory neurotransmitter GABA. This leads to sedation and impaired cognitive function. Over time, the brain adapts to the reducing GABA sensitivity, which increases glutamine activity. The increase in glutamine activity contributes to tolerance and dependence. Withdrawal symptoms occur when alcohol use is stopped. This is due to neurochemical imbalance. Chronic alcohol use also affects dopamine pathways, reinforcing addictive behaviors, which can lead to long-term damage to the liver, heart, and other organs. Now I'm going to talk about how genetics play a role in one's risk of developing alcohol use disorder. So scientists have studied this, and they have discovered that the genotype ADH1B and ALDH2 gene is responsible for one's increased risk of developing alcoholism. These genes, if one has it, they experience earlier onset of symptoms. The ADH1B gene associates with more frequent blackouts and severe withdrawal. These are linked to higher ICD-10 scores. And so what is an ICD-10 score? It is a code for finding alcohol in the blood, and it's used to specify blood alcohol levels. If one has a family history of alcohol use disorder, they are more likely to develop being dependent on alcohol.
Alcohol metabolism genes. So this slide would cover how genes and enzymes affect alcohol metabolism within the body, mainly dividing these metabolism pathways into two pathways that are primarily conducted within the liver, which are oxidative metabolism pathway and the non-oxidative metabolism pathway. But we'll also be discussing how metabolism happens and is precipitated and affected by the brain, the kidneys, and the digestive tract, to include, or mainly including, the stomach. Some enzymes that aid in the metabolism of alcohol in both oxidative and non-oxidative pathways. So alcohol is primarily metabolized through two pathways within the liver, which are oxidative and non-oxidative. The oxidative pathway involves alcohol dehydrogenase within the cytosol, which converts ethanol to acetaldehyde. Now, this is a very complicated process, and we're only covering the basics here in order to be able to further down the line understand pharmacokinetics and pharmacogenetics. Following this, aldehyde dehydrogenase, or ALDH2, within the mitochondria converts acetaldehyde to acetate. Then you have cytochrome, which is CYP, or in this case cytochrome P450 or cytochrome 2E1 within the microsomes, which is especially active at high ethanol concentrations or chronic use of alcohol. And this again will be important down the line for pharmacokinetics and genetics when we discuss some of the active medications that are available and approved by the FDA in the United States for the treatment of alcohol abuse and alcohol addiction. And lastly, the other enzyme within this pathway that we're going to talk about here is catalase in the peroxisomes, which is uses hydrogen peroxide to oxidize ethanol. This is marked as a minor pathway within the oxidative pathway, but it's also important as it will have an effect down the line in the understanding of targeted medications or targeted therapies for alcohol addiction. The two main non-oxidative pathways that are talked the most about in literature are the fatty acid ethyl esterase, or FAES, which is synthesized and it has an implication in the pancreas or pancreas damage and pancreatitis in some cases. Lastly, you have phosphothidylethanol, which is produced by phospholipase, which can disrupt cell signaling, and it goes by the letters of PLD. So now that we have a brief understanding and a brief general knowledge of the different enzymes and different pathways within the liver and the including the oxidative and non-oxidative pathway, we can briefly discuss some other organs and some other specialty functions within other organs that are that affect alcohol and that are affected by the metabolism of ATOH. Since the brain also uses one of the catalysts that we talked about before, the CYP2E1 and catalase, especially on patients that have low levels of alcohol dehydrogenase, to be able to metabolize or aid in the metabolism and the primary conversion of ethanol to acetaldehyde for the body to be able to process. We also have the stomach, which gastric acids contribute to the first pass metabolism of alcohol. And since we talk about first pass here, again, this would be important understanding medications first pass and down the line, and when we discuss some brief pharmacokinetics and pharmacogenetics and understanding first pass, second pass, and such liver metabolism and GI tract metabolism. And lastly, we have other issues that can present within the kidneys, such as issues with antidiuretic hormone and things that will cause other metabolites derangements down the line, such as inhibiting antidiuretic hormone and causing dehydration to a degree, which can cause hypernatremia, which can cause other problems down the line, neurological problems, demyelinating disease when there's hyponatremia or hypernatremia, cardiac dysrhythmias. So many things could arise from the genetics of how ATOH is metabolizing within our body, and how this could affect in terms metabolic rearrangements, cell proliferation and cell division, which could lead to other issues such as cancer. And the main thing that we're talking about here, then the oxidative and non-oxidative pathways of metabolisms, including first pass metabolisms and such, which will affect drug therapy in the future. Generic variations profoundly affect an individual's physiological and behavioral response to alcohol, including tolerance, risk of addiction and reward, and treatment efficacy. ALDH2 polymorphism leads to an inefficient metabolism of acetaldehyde, which results in its accumulation. This causes symptoms such as facial flushing, headache, and nausea. This can in turn naturally discourage some from consuming alcohol and then naturally prevent the disorder of alcohol use, given that they have unwanted side effects when they try to metabolize ethanol. The ADH1B variant results in a faster conversion of ethanol to acetaldehyde, which enhances its adverse effects, which is very common in East Asian and some Jewish population. It also contributes to the reduce of the alcohol consumption. In contrast, the OPRM1A1AAG gene polymorphism alters the binding affinity of opioid receptors to endogenous endorphins, carries out the G-allele expressive greater reward for alcohol, but also responds better and turns to medications such as naltrexone, which is an opioid antagonist, but it has also been approved by the FDA for the use of alcohol use and the management of chronic alcohol use. And briefly, it acts as removing the reward that we feel when we ingest this highly addictive substance. So it is believed to diminish the urge to consume alcohol and opiates, since it reduces the reward. It does not reduce the effect that the substance have on the body, and in this case alcohol, the very big effect on the liver, but it does reduces the reward of consuming the said substance, so it reduces the want or the need for patients to consume alcohol or opiates in this case, which is medication that is used for both. Not all, but some of the effects of alcohol in behavior and some people's behavior clinically and subclinically, outside in the world consuming alcohol, or clinically when they come with symptoms of not necessarily alcohol withdrawals, but alcohol dependency. The serotonin transporter 5-HTTLPR and then dopamine receptors DRD2 can cause traits such as variants in this gene can cause traits such as impulsivity, stress response, and emotional deregulation or lack of emotional regulation, which all impact drinking behavior, as it might create a behavior of returning to drinking to feel for some that they're not in that state anymore. Now, as I said before, pharmacogenetics is an emerging field that leverages these genes differences to target more of a medication that is gene guided or gene therapy, and there are certain individuals, such as those with the OPRM1 gene, that are candidate. There are good candidates for drugs such as naltrexone, and there's some others that are not good candidates and might be intolerant, such as the ones that have the ALDH2 gene. As generic screening becomes more available in the future and less costly, perhaps it would be great for FNPs to stay up to date, to better use these modalities to support our patients with addiction disorders, such as alcohol. Alcohol addiction is a chronic relapsing brain disorder, which is marked by a loss of control over alcohol despite having negative consequences, and despite the subject knowing that negative consequences are taking place while consuming alcohol. A major treatment challenge for this, though, is that about relapses occur in about 50% of those that have been abstaining for alcohol within the first 3 months. And for the FNP, it's important to consider that relapses are often triggered by stress, environmental cues such as social drinking, and it is important for the FNP to bear in mind that providing not only targeted therapy and not only this complicated jargon of genetics and complicated education, mental health, it's a great asset to have on your side as not only as a referral to, but just using those therapeutic communications to reach your patients and provide that support that they need, despite what gene variation they have. It's important to consider you're treating a human, not just an addicted human. So family nurse practitioners and family care providers overall, they're well positioned to provide a comprehensive approach to include taking a family history and behavioral screening, and aiding in the management of alcohol use disorder and alcohol abuse. Primary care providers should also remember, I know in the previous slide we discussed how it is important to remember that we're treating a person with addiction, not just an addiction. It is also important at the same time to have some standardized measures to evaluate our patients and evaluate how effective our treatment interventions are, and evaluate their risk before we even have to implement treatment interventions if we have a suspicion for or a good family history of substance abuse in the family. It doesn't have to be alcohol, but any substance abuse, but even still more important if it's alcohol. So there's some standardized testing such as AUDIT, Alcohol Use Disorder Identification Test, and then SPIRT, which is the screening, brief intervention, and referral to treatment tools. So these tools can aid in the assessment and reassessment of alcohol use disorder and the risk, and to help mitigate the risk for alcohol use. While we're doing this, again, it's important to consider ethnicity. As we discussed before, some individuals from certain ethnicity will have different affinities or different genes that will naturally divert them from using alcohol, or reduce the reward for using alcohol. And then some gene or drug directed therapies will be better than others. But in the overall population, it is important to address mental health. And once again, not only screening for mental health as it relates to alcohol, but more often than not, screening must and has to include other comorbid mental health conditions such as depression, PTSD, anxiety, which are strongly linked to alcohol. But also, it is important not to forget physical conditions, disabilities. Not being able to do the things that you used to do before could lead to an increased use in alcohol and create an alcohol dependency. So while genetics is very important in understanding overall the basis of alcohol, the supportive and mental health aspect of the use of alcohol, whether the person is going through a debilitating physical condition or just has underlying mental health problems, it is important to address the risk and benefit and have the proper risk assessment tools to be able to do that. And in the primary care, lastly, genetic testing will not be a routine measure, but at this time at least, but it is important to increase the awareness that there are targeted drugs and targeted therapy, which might be a trial and error if genetic testing is not available, or is very costly, or like in the healthcare that we practice is not reimbursed by insurance. Some medications might just need to be trial and error and obtain a good history on our patient and a good family history, and perhaps that way we can provide better targeted therapy without necessarily having to conduct genetic testing. So what do we do for the acute management and prevention interventions as a family FNP? So for the acute management or the chronic management, either way, in your primary practice, you're going to provide the risk assessment that we discussed. You're going to provide some brief interventions, mainly to discuss what led the patient to alcohol or to the addicting behavior. And you're going to do this through motivational interviewing and through, emphasizing empathetic and non-confrontational dialogue. And, it is very important to support the autonomy in decision making. We want to express to them how concerned we are about the ongoing issue that they might be having, but recognize that the word alcohol might be triggering for them. So just having a very aware and alert understanding that providing a motivational type interview might be the best first approach, the best acute approach to a newly found alcohol use disorder. Also, we have to consider the pharmacological aspect of it. Despite providing this mental health and this therapeutic communication that we will provide, pharmacological interventions should be considered. And we've already discussed naltrexone. There are 2 more medications, but I chose to only discuss 1 more here, as is the other medication I saw as to the most research out there that appears promising, and it's called acamprostate. It's very difficult to pronounce, but the research finds that this medication is good as an adjunct to psychological interventions again. The standalone use of the medication did not show much improvement, but a study by Plosker in 2015 demonstrated that between 3 to 12 months of abstinence of alcohol was significantly improved versus the placebo group when used in conjunction with mental health therapy for the abstinence of alcohol. So once they arrived to not being able to use alcohol, remaining without their use of alcohol again. Now, we have to be mindful about the genetic differences again while using each of these therapies, and also know our limits. Collaborate closely with behavioral health, social work, and community-based services depending on where you live to aid and support alcohol dependency and alcohol use disorder. Some of the key things to mention to patients or to educate your patients on, besides being supporter, is making sure that they understand the alcohol systemic effects, making sure that you provide them with harm reduction therapies. Even if they're not ready to quit right now, you provide them with strategies to reduce harm, and always advise and considering the use of alcohol with consider that the use of alcohol with other medications can be very detrimental, precisely acetaminophen and the consumption of alcohol. And then also provide some long-term goals and support planning, create SMART goals for them. Of course, that are measurable, time, attainable. It would be a good one to remember, even if they can't do this right now, have or help develop a plan to get there, even if it's a long-term plan. And if you're concerned for a more immediate danger to the patient, then you should refer to psychiatry services and have them evaluated further. But don't forget about those long-term support and long-term plans for your patient. And then what are you going to do after all of this? You're going to track adherence to treatment. You're going to monitor relapse triggers and just support their lifestyle modification efforts over time. This could be very stressful times. There are some very high financial stresses out there, so now more than ever. And also, it's not talked about enough, but after the pandemic, I anecdotally noticed a huge hike in alcohol consumption and ATOH withdrawal in the hospital, landing people in the ICU. So this is real and this is important. And I'm glad that there's some gene-guided therapy out there, some medications that I was even not aware of that were used for the treatment of alcohol abuse. Just bear in mind, I have some recent experience from working in a pre-liver transplant unit, and some of it was non-ATOH cirrhosis, but I want to say that the greater of the population was ATOH cirrhosis and complications from cirrhotic and fatty liver disease that causes a range of all problems like hepatopulmonary syndrome, hepatorenal syndrome. They often end up needing dialysis and end-stage liver failure and kidney failure, and pulmonary hypertension. There's a huge amount of ramifications that could happen because of the inadequate and excessive use of alcohol. So it is important to remember all of this in the treatment of our patients.
Alcohol use disorders needs a culturally sensitive approach with ethical considerations. Ways to do this include avoiding stigmas and respecting a patient's autonomy. Alcohol use disorders should be approached as a medical condition, not a moral failing. This can exacerbate alcohol use disorders and negatively affect a person's emotional state. Shared decision making also respects patients' values and preferences. Certain cultural norms and religious beliefs may also influence drinking patterns and help seeking behaviors and impact treatment acceptability. You also want to be mindful of disparities in access to care and genetic diversity. Only 5.4% of adults with alcohol use disorder in the United States utilized treatment in the last year. Alcohol use disorder treatment utilization did not significantly differ between white males and other racial, ethnic, and gender groups. However, disparities were identified among Medicaid enrollees and those who were uninsured. Future directions in genetic research include developments in alcoholism treatment and the genetics of alcohol dependence using genotype information. This may make it possible to match patients with specific treatments. For example, finding the presence of a specific allele predicts a better response to naltrexone treatment. It is recommended that whenever possible, treatment trials include the collection of DNA samples to permit pharmacogenetic analysis to look for relevant genetic variation. Integration of genetic screening in primary care could also identify genetic risk factors earlier and may enable prevention strategies. In summary, alcohol use disorder is a medical condition that affects many Americans at a large cost. Alcohol metabolism occurs primarily through liver pathways, oxidative and non-oxidative. Additional metabolism happens in the brain, stomach, and kidneys. Genetics affect physiological and behavioral response to alcohol, including tolerance, risk of addiction, and treatment efficacy. Early screening, patient education, and individualized care are essential. FNPs play a pivotal role in both acute and long-term management of AUD. FNPs and clinicians can better match treatment modalities to a patient's genomic profile, increasing adherence and outcomes. FNPs should use a comprehensive risk assessment approach.